We request our panel to please take the chair.
We welcome our first speaker, Dr. Vanati Murugeshan Madam, to give her talk. She is going to speak on tissue adhesion keratoplasty, the current perspectives.
We would request all our audience to keep their questions. We would take them at the end of the session to make the talks more crisp.
Yeah. Thank you so much. Yeah. So I think it's about 8 minutes, so I would just have time to flip through my slides, I guess. Yeah. So I'm going to talk to you on the current perspectives of tissue adhesion keratoplasty here, no financial interest here. So one thing when we are talking about lenticule related surgeries, so one, we have lenticule extraction procedures which are refractive, and we have tissue adhesion procedures using lenticules here. And I think I wouldn't delve into the nomenclature part of it and directly take you on to tissue replacement procedures here. So we'll skip the initial parts of the lenticule extraction refractive modules here. So I would request you to go and refer to, if you are interested, there's a comprehensive review in the latest edition of Indian Journal of Ophthalmology, which does give you a comprehensive overview of current literature on lenticule adhesion keratoplasty here. So from what we see is most of the literature, it's not much, but whatever we have, I think lenticule adhesion keratoplasty is here to stay, and it is evolving, and we probably need to have a little more understanding of how this is going to influence, or what is the role it's going to occupy in the management of our keratoconus spaces. That's largely where we are going to use it, because it's going to improve the tectonic integrity. It's going to thicken our corneas here, and it's probably going to bring out a refractive change. So whether it's going to give a visual outcome that is acceptable, and it's going to replace replacement tissue replacement keratoplasty procedures, is something which we will probably understand in the coming years here. When you look at tissue adhesion keratoplasties, what we largely have is the first three. We'll have the Bowman's layer transplantation, the corneal allogenic intrastromal ring segment implantation, the CARES, and the femtosecond intrastromal lenticular and the intrastromal keratoplasty there, and the last one. So these are the three replacement procedures, tissue replacement procedures, which we could probably adopt in management of our keratoconus cases here. So when we look at Bowman's layer transplantation, it is a novel approach, but it has a learning curve here. The tissue preparation is slightly more challenging than a routine keratoplasty, and whatever we have in terms of results and success rate is about 70 to 75% of success rate in helping to arrest a progressive keratoconus, or in helping to give a visual outcome that is acceptable in these cases here. Some of the complications here is landing up with perforations and infections as expected when we are doing a lamellar procedure. So literature is not replete with lot of articles on this. We currently just have about 3 or 4 authors who have shared our experiences, and when you look at long-term results of Bowman's layer transplantation for advanced keratoconus, we have results which are over 18 months follow-ups. We have one other larger one which talk about their 5-year results here, and most have indicated a success rate close to about 85% in 5 years post-operative, and they do advocate this as a replicable procedure or a reliable procedure here. I per se do not have an experience with Bowman's layer transplantation. A Bowman's layer onlay grafting for keratoconus is also a variation which has been described with just about one study on 20 eyes, and which also is claimed to produce acceptable results in these patients here. So when you look at the other tissue adhesion keratoplasty, it's not per se an 8 millimeter diameter graft, but then you're looking at a procedure where you instead of intacts, you're going to look at using intrastromal ring segments which are created using allogenic tissue here by a specially designed trephine, and these are inserted onto a particular femtosecond created channel here, and you can decide of how you want to put asymmetric or asymmetric ring segments here, and there is a marker onto which it's placed on depending on what is the length you would want to do. There are a few variations again described by Susan Jacob and her group, and it's quite interesting to look at their results, and they do claim, this is some of her postoperative pictures which Susan has shared with me, and she does say that there's a significant amount of flattening which one can obtain even in advanced cases of keratoconus, and there are only 2 large-scale studies which talk about the reasonable follow-up methodology, and it is being advocated as one of the methods where you could use these human allogenic ring segments for producing flattening of progressive keratoconus, and can combine it with collagen cross-linking as well. Coming to the third, which I think there are pockets of people across the world who are probably looking at intrastromal keratoplasty, where a femtosecond created channel in the donor in the host keratoconic cornea, and the lenticule which is then cut out using a microkeratome or fashioned using a femtosecond laser itself, is then used is implanted into the lamellar dissection here, and this will help to cause the tissue adhesion here. So I'm sorry, I think I'm not using my laptop, so this is not doing well. Here is the femtosecond channel which is created in the donor keratoconic cornea here, and this is a progressive case of keratoconus here. The Moria microkeratome is used to fashion out a donor lenticule about 200 microns here, and this lenticule is then placed in the femtosecond channel which is created in the donor cornea. So that's the lenticule which is implanted as a lenticule adhesion keratoplasty, alcohol aided removal of the keratoconic cornea, and this is then treated with exposed to collagen cross-linking here. So I call this keratoconus plus, and I'll just share a few of my initial results of 10 patients. I have about a year's follow-up for all of them here, and just a peek into the results which I have obtained in these cases. These are the follow-up pictures, the amount of flattening which have been induced during the follow-up, and as you can look at the linear graphs here, 5 out of the 10 patients had improvement in their unaided visual acuity in the post-op period, and 7 had improvement in their best corrected visual acuity here, and all these show that they do bring a change in the corneal curvature here. Watching their IOP is something you need to look at, because you need to look at the biomechanically corrected IOP in these patients. Well, this procedure does bring about structural integrity, does cause a significant corneal flattening in these patients, and does work in producing stability of these corneas and the change in some of the corvus biomechanical parameters here. Visual acuity also showed a significant, but I didn't find a significant change in the corneal aberration. So currently probably it just is an alternative to those cases of progressive keratoconus where the cornea is too thin here and it's not amenable to the conventional protocols, and you can probably use it as an alternative and combine it with collagen cross-linking. I'll stop here and thank you for your patience.
If you don't mention one quick question, so you take lenticule with Bowman layer, yeah?
Yes, so this lenticule comprises of Bowman's with anterior
And some stroma.
Yes,
and the idea is probably to increase the mechanical or biomechanical strength of the lenticule.
Sort of causes the tectonic integrity sort of improves. So we took those cases which are not amenable to collagen cross-linking because they've gone thin beyond the face, and we created a femtosecond channel here, and then implanted these lenticles created using the microkeratome, and the donor cut diameter was around 8.5 to 8.9 millimeters into these channels here, and we looked at what is the refractive change this is producing here. So it does cause an acceptable flattening, but patients would still need contact lenses after that, but then the quality of vision is probably better. But currently with the available modules, the eye trace is the only one where you can sort of quantify to see how their MPFs are changing here. So quantifying, and patients do say their quality of vision is better than what they had without an intervention. But vis-a-vis when you compare to DALK, I still find DALK is the better procedure. You have only a single interface here, and I still am more confident offering a DALK. So I did see this procedure being adopted by a few, and they did claim, so we thought we need to do a systematic evaluation for us to have an understanding how it really causes changes in both in the anterior and the posterior curvatures and how the visual acuity changes. I still feel it's an alternative modality where you probably don't want to take them for a patient is not willing for a DALK, patient doesn't want to wear a contact lenses, then you use it as an alternative, and it does produce an improvement in visual acuity, but the best possible quality is with the DALK, not
And-
comparable. I have a patient who has an intrastromal in the right and the DALK in the other. He's DALK, he's 6'9" unaided. In this, he's gone to about 6'18", and with glasses improves to about 6'9", but the quality of vision, he's not very happy.
And I believe this is a category of patients without central corneal scarring, so it's with clear cornea.
Yes, clean corneas without
Okay,
scarring.
okay, thank you very much. So let's go to the next speaker. Yeah.
Yeah, I think I'm audible. Good afternoon, one and all. I'll be talking about DALK in complicated and extreme situation. So let's start with the first situations. Which are the situations which can arise? So sometimes they can be related to pre-op condition of the cornea. As you can see from this case, this was a perforated descemetocele which was due to herpes simplex viral keratitis. When I saw, there was no obvious infiltrate there, but there was a large perforation which was there. So I decided to do a DALK there. The perforation was large enough, and I was a little concerned that how it's going to plan out. But as it was something which possibly had left rest of the cornea uninvolved, I thought of trying out DALK there. I did not try to bear the descent membrane there. Basically, you want to do a deep DALK there, and as the residual bed was not deep enough, I had to thin out the donor cornea there. The surgery was good enough, and then after putting the suture, 8 sutures, I put air bubble inside and remove all the anterior synechia, whatever was there. Post-operatively, well, patient thankfully didn't have double anterior chamber, and last follow-up patient did very well and had vision almost 6-12 parts. Remember, we could have had a full thickness graft with possible all the chances of rejection and everything. So doing a DALK in such kind of situation still can work. The other pre-op situation which can be complicated is keratoglobus. These kind of thin cornea can be quite bad. Well, what I'm doing here is I'm trying to save the limbal palisades there. So I'm removing the limbal palisades, pushing the conjunctiva back, and then manually deepening the marking which I made with mitrifine. Again, we made a pocket there, and it's a tuck-in DALK, so we made a pocket, and of course we are not bearing the descent membrane here, and we are going deep DALK. I do a little modification there. I try to use almost same thickness corneoscleral rim there, just thin out small amount of sclera from the periphery. And then after putting 8 suture, you can start tucking in the cornea, and which ultimately goes inside quite nicely. Once you tuck in all the cornea and put all the sutures in place, then possibly it's the time to replace your limbal palisade which you had displaced earlier. What it does is it prevents any chances of epithelial healing related issues, and ultimately you end up having a significantly decent outcome. Thankfully, post-op patient had an excellent visual as well as the optical outcome. Another complicated situation can be ocular surface related. As you can see from here, really bad ocular surface with bad similar front, all those things. Very thin cornea, and had to confirm that there was a cornea available there. Please make sure that you do an ASOCT to make sure what lies behind that pannus. So I planned 3-step procedure. The first step was symblepharon release and pannus resection with oral mucous membrane graft, DALK, and amniotic membrane. And the second step was slit from the other eye, and third step PKP. So the first step, what we are showing here, as you see, then these kind of advanced surface related damage, you can't put a speculum. So I put a lid suture first. I'm trying to save the pannus tissue here, which I could use to form my fornix there. So I'm not sacrificing the semblefront tissue there. I removed all the fibrovascular scarring, and now I put the speculum. Now that pushes my pannus tissue in the periphery. I'm taking oral mucous membrane here, and after thinning it out, I place this oral mucous membrane on the surface, and I'm trying to use this oral mucous membrane on peripheral bulbar conjunctiva to prevent any semblefront occurring there. Remember, my goal is not to regenerate the ocular surface here. My goal is to make the way for the future surgery where I am going to do slit from the other eye. Post this thing, I did an amniotic membrane on top of it, an overlay on top of this. Patient did well and underwent all 3 steps and had an excellent visual outcome. Sometimes the factors can be intraoperative. Now here intraoperative factors can be many of them. Many times, in fact, every step of DALK, big bubble DALK, you have potential of perforation there. Maybe the beginning where you are just trying to deepen the groove and you can have perforation, you can simply take suture. Or sometime, if you are not lucky enough, then your trephination can end up having perforation. As you can see from here, I had a new trephine in my hand and I ended up having a very large perforation, which was almost more than 200 degree perforation. These kind of perforation are difficult to deal with. You may want to convert to PKP, but what I thought was, as it was not complete, I put 3 stay sutures in the area of the perforation, where the opposite area, which was still intact, I started doing dissection from there. Left behind some small attached area here, and then put the donor tissue there, leaving behind the sutures which I had taken, and finally the last suture, 12 o'clock, I took a full thickness bite there to include my recipient which was there, put an air bubble, and I was concerned about double anterior chamber. Thankfully, there was no double anterior chamber, patient did well, and I could do a DALK there. Sometimes we hear these unique pop sound where we are doing a big bubble DALK, you are injecting the big bubble and big bubble gives away and you end up having a pop sound. So one such case, well, I was making a groove there on the cornea, and then once the groove is made, I decided to make the big bubble there. I don't know whether you can hear it, but yeah, the video has a pop there, and I heard the pop and I knew that, okay, it's gone. You could also see the multiple bubbles in anterior chamber. I had 2 choices, either I convert to PKP, or we know that hydrops cornea also, they hold the descent membrane. Descent membrane does not go away. So I decided to go manually in deepening the dissection, and I could still see the gap there. And thankfully I could salvage my graft and I could do a DALK. Interestingly, that area remained a little bit scarred, and patient could achieve 612, but patient was still happy. In hindsight, when I seen ASOCT, there was a scar which was deep enough, I should have avoided DALK. So DALK can safely be performed in complicated and extreme situation. Different steps of DALK can lead to perforation, but most of the time you may be able to salvage these cases. Thank you very much.
Thank you, Dr. Himanshi, for those brilliant videos and talk and tips. I would like a comment from the panel members.
I think it was a very good collection of difficult cases, and congratulations, you managed it well. So, although I know that when you're having a big giant tear, and this is a phakic eye, and you place the air or gas into the air bubble, so at least in my hands, it's not infrequently to expect Urit-Zavalia syndrome because of the pressure. So any special comments on that? How would you avoid this issue that is not infrequent in this case?
So that's an excellent question. Thankfully, because of DMEC and DSEX, we have got brave enough to now leave the entire chamber air bubble. Usually what I do is I keep the full air bubble for a couple of hours and then I deflate it on slit lamp or in OR, make it to the level where the air bubble is free enough and it's not stable. Of course, there are chances that you may end up in a pupillary glaucoma there. Have to be aware of this thing. But thankfully, with our understanding, we know that most of the time we are fine. The other thing is when the intraocular pressure is high, the bubble falsely shows as smaller because the air gets compressed inside. So it's very important to make sure the intraocular pressure is reduced when you are deflating the bubble and make sure the bubble is mobile. And I think we should be fine.
You do peripheral iridectomy or not?
In most of the cases, yes, I do. In this case, no, I didn't.
Thank you very much, Dr.
Thank you.
Himanshu. Now we welcome Dr. Sunita Chaurasia Madam to come and give her talk on surgical management of stromal dystrophies.
On the surgical management of stromal dystrophy. We know the traditional classification has been replaced by the addition 2 of IC3D classification of corneal dystrophies. And now we also have the edition 3, which was published in Cornea Journal 2024. So when we talk about the corneal dystrophies, there's a whole list of dystrophies under various categories. And strictly speaking, under the category of stromal dystrophies, we have the macular and Schneider's and many other dystrophies. But primarily I'll be dwelling only upon the macular corneal dystrophy for this presentation because of its commonalities. This is one of the most common stromal dystrophies which is seen in India, and we also come across the similar pattern in our LVP data. Typically, the clinical picture of macular dystrophy is something like this, where it begins in the first decade and deposits increase with each passing decade, initial deposit being superficial, and then later coalesce to reach the limbus, and this is what the current textbook description of macular dystrophy is. The genetics, it's caused by the mutations within the CHST6 gene, which leads to deposition of abnormal gags in the corneal stroma, keratocytes, DM, and the corneal endothelium. So when we look back into the dystrophies management, the earlier times, the PK was the standard practice of management of stromal dystrophies. And 2007-8, when there was a rapid popularity of DALC surgery, DALC was gradually adopted in the management of macular corneal dystrophy. But over time, we have realized that macular corneal dystrophy may not be ALK may not be an automatic choice in management, and we have to have certain considerations when we plan management in these cases. Looking into histology, the histology shows accumulation of glycosaminoglycans in the stromal lamellae within keratocytes and endothelium. But apart from this, there's also thickening and excrescences or guttae in the Descemet's membrane, much like what is seen in Fuchs endothelial dystrophy. These have been mentioned earlier incidentally, but have not received much attention, and this is a very important point of great relevance in the management. So with respect to posterior membrane or DM endothelial alterations, despite these DM endothelial changes, good visual outcomes have been achieved with DALC in the vast majority of eyes. However, it is also important to remember there have been inconsistencies in the DALC outcomes which have been seen over a period of time. I'll present some clinical observations and research of past several years, and which will lay down some kind of guidelines on the management of macular corneal dystrophy. We looked into the specular microscopy following DALC in patients with macular corneal dystrophy. And this is what a typical specular microscopy in a macular corneal dystrophy which has undergone DALC looks like. So these were 3 different cases, and we can see the Fuchs-like excrescences or guttae following DALC in these cases. This is one patient where one eye was DALC and one eye was PK. So we can see the specular imaging of a PK eye versus a DALC eye, how it's very variable. Visual outcome is good, but then there's a lot of morphological variations on the endothelial imaging between the 2 eyes. We looked into the histology of the Descemet's membrane endothelium in these patients who underwent PK in the past. And when we compared with the normal corneas, other cases where there was no macular corneal dystrophy and some other indications, we see that there's a thickening of the Descemet's membrane. This is a consistent feature in the histology of the macular corneal buttons, and there are guttae-like excrescences just like what we see with the Fuchs endothelial dystrophy. That apart, we incidentally came across 3 patients of primary graft failure after uneventful DALC. So these were cases where the DALC was uneventful, but the primary graft failure occurred, meaning that there was no recovery of the corneal graft clarity in these eyes. Subsequently, we revisited the outcomes of DALC in macular corneal dystrophy to assess what are the preoperative risk factors for graft failure. And this was a study which was undertaken, and factors affecting graft survival in DALC was studied in several eyes where it was a type 1 DALC done, type 1 big bubble DALC done rather than manual dissection. So the results what showed was that the younger age at surgery certainly showed a better visual acuity. The older age at surgery was a risk factor not just for the overall graft failure but also for primary graft failure. So what were the conclusions of the study? The deposits, as we know, in macular dystrophy increase with age, and hence age has a bearing upon the time when we plan the surgery. So with advancing age, the deposits tend to increase in more intensity and degree in all the layers of the cornea. Patients who undergo DALC at an older age should also be explained about the possibility of suboptimal outcomes because they may have a higher risk of endothelial failure. There is no defined age at which endothelial function gets compromised, but surrogate measures can help such as pachymetry, OCT and the UVM. And when cataract surgery is needed post-DALC, the possibility of secondary endothelial failure should be discussed in these patients because they have a compromised endothelium. I'll share a few more atypical cases of macular corneal dystrophy. This was a patient who presented with primarily lesions which are localized in the peripheral part of the cornea, and the DM was severely thickened. Excuse me. So as we see in the Descemet's membrane of the OCT pictures, the DM is grossly thinned down. So primarily the deposits are in the peripheral region, and if you see the central cornea shows booting. And this particular patient was managed not with DALC, not with PK, but with DSEC. Another similar description has been reported from a case in US by David Group, where similar kind of findings were noted in a case of macular dystrophy. Now there's a whole lot of clinical diversity in macular corneal dystrophy, and this is what the 4 patterns which we studied were. There was a pattern where the deposits are more in the stroma in the subepithelial region of the central cornea. Another pattern showing deposits in the stroma, subepithelial region in the central cornea, and the predesmetic peripheral cornea, which are non-contiguous. There are isolated predesmetic deposits in the peripheral cornea with minimal stromal involvement, and then there are instances where there's a diffuse stromal deposits, subepithelial involvement, and overall thick cornea, which shows that the endothelium is compromised in these eyes. So these have implications, and these diversity of presentations have implications in the choice of the surgery, and each clinical scenario has to be dealt carefully with utmost attention to these clinical findings. So this is just sharing some cases. A case where there's primarily a central deposit in the center, there's an overall ground glass haze in the cornea, but main deposit is in the central visual axis as a subepithelial lesion. This is one case where there are subepithelial lesions in the center, along with peripheral deposits which are there in the predesmetic region. Another case where there's a thickened Descemet's membrane with deposits in the peripheral region. This is one case of advanced case where there's a diffuse lesion all throughout, and there's a kind of a backshadowing on the OCT imaging. The pandemic year taught us few more things where keratoplasty was limited, and then we explored the role of PTK in macular corneal dystrophy. And this was a patient who came with a severe photophobia, and he had a trauma in the left eye. So in this particular case, we see that the deposits are primarily in the subepithelial and in the epithelial region. And this is a reason why these patients present with severe photophobia. So in this patient, PTK was done. Why PTK? Because photophobia was quite significant. Refraction was not possible, deposit was superficial, and we wanted to do an interim procedure which requires a less frequent follow-up. And this was the outcome in this patient, where we could refract the patient. The right eye has cleared beautifully well, and then when we could refract, the patient's vision improved to 20/30, 20/40 in the left eye. So in the decision making of management of macular corneal dystrophy, the algorithm which I will put is that age of the patient is important criteria. Less than 40 years, maybe DALC or PK may be an option, but above 40-45 years, the time when the cataract also starts developing, PK is a better choice. Nature of deposits can be characterized by clinical examination, OCT and UVM. If they are superficial in the visual axis, PTK can be done as a measure to avoid or delay transplant. Thick DM, increased pachymetry is an indication for doing a penetrating graft in these patients. Thank you very much for your kind attention.
That's interesting. I just have one question. In my own experience, I have realized that when I do cases with macular dystrophy and I attempt a big bubble, I do tend to notice that there's a slightly higher tendency towards perforation. I don't know if this is something that everyone else observes. And my second question is, if there is evidence of significant DM thickening, suggestive of endothelial compromise, would it then be better to stage it? Probably do a lamellar DOLC procedure first, followed by a DSEC or a DMEC, instead of doing a PK, because we know that PK long-term outcomes are not that great.
Yeah, the first question about getting a chances of perforation in macular corneal dystrophy, I think one of the reasons for that is the cornea being thinner in these cases, our judgment and optical clarity being a little compromised. That could be one reason like we landed with a perforation. That's my personal belief in the cases where I had a perforation, so maybe the judgment was inappropriate. The second thing about having a graft failure, I think the chances of when there's a primary graft failure is much more. Rather, you'll want to bank on a procedure which has a more predictable outcome. So cases where DM is thickened, because the optical outcomes where the DM is thicker is not very good for macular corneal dystrophy. In patient where you had one eye DALC with thickened Descemet's membrane, one eye PK done, they always prefer their PK eye better in terms of visual quality. So yes, those are problems of PK where you have wound dehiscence, rejection, all that. But I think for me, what I have done is I've shifted to PK for patients where DM thickening is quite significant.
Thank you.
Thank you so much, ma'am. May I now request Dr. Rishi Swarup sir to speak on no bubble, no trouble.
Thank you. At the outset, I'd like to thank Dr. Somshila for involving me in the cornea sub-day. And I'll be sharing my technique of DALC. Can I have my slides, please? Yeah? Yeah. So I call it the groove and peel technique. So GPT is in vogue nowadays. So this is the DALC GPT. So if you don't get a bubble, no trouble. You can still do a good DALC if you follow these steps, and I'll just share with you my simple steps to do this technique. So when would you want to do a manual DALC? If you've attempted a big bubble and if it hasn't worked, then you can always fall back on a manual DALC. And if you have an advanced or an extreme ectasia, like you don't have too much of working space to put in a cannula or a needle to do a big bubble, or if you have a peripheral ectasia like a pellucid where your type 1 bubble will not go, or a high-risk graft where you just don't want to have a complication like a perforation. If you have involvement of the posterior cornea like an old hydrops, or a patient who's had a scar involving the Duas layer, or if there's any other contraindication for a big bubble, like the OCT there showing an old hydrops. So what are the challenges with the usual manual techniques that we know? Usually you do a layer by layer dissection using some sort of a sharp instrument, maybe a crescent blade or some other sharp instrument. You can end up with an irregular bed. You can have some stroma left behind. You can end up with a chance of a perforation because you're using sharp instrumentation. And this technique essentially becomes very skill dependent, and the repeatability becomes lower. So that is why I think this kind of a technique is useful. This is called the groove and peel technique. So groove, because initially you're creating a partial thickness refine, which is like a groove, and then once you reach the right plane, you just need to peel off the stroma. So in this particular case, we have attempted a visco bubble, which didn't happen. So my threshold to convert to this technique is very low. So we marked out the cone. This was a case of keratoconus, and this is what I use. I use some sort of a blunt scissor. In this case, we're using a universal corneal scissor, and just do a scissor dissection underneath the refined edge, and then you can go 1 or 2 spirals going deeper with each pass. So all your dissection with the scissor is in the peripheral cornea underneath your groove under direct visualization. You go in with your scissor closed, and then you open it to kind of just open up that space, and then you cut that ledge of stroma which you've dissected. So you keep doing this till you see about 2-3 clock hours of the glassy Duas or the pre-descemetic layer. Then you just grasp that central island of stroma, give counter pressure with another forceps, and using stretch forces which are distributed over a larger surface area, you can easily peel this entire stroma off, even the areas where you have not dissected. So because the stretch forces are distributed over a large area, you don't really put so much pressure on the deeper layers, and the chance of perforation comes down quite a bit. And you can see after putting fluid, the interface is going to be very clear. And you can do it again and again. I've done it now in hundreds of cases, and the key is to start peeling when you are at the right plane. If you're too superficial, you'll get resistance, and then you're not at the right plane. So be at the right plane, and then you can easily do it. So we've designed this scissor from one of the Indian manufacturers, Joja Surgicals. I have no financial interest. And you can see that we've made a paracentesis to decompress the eye before we go to the final step. So the advantage of this scissor is that it's, this is not the scissor. The scissor has a narrower tip, and it's got a blunt, flat profile. So you can keep dissecting in the same way quite easily. And at some point, when you encounter the tuas layer, you just peel, and if it's peeling off easily, then you're in the right plane. So just slowly you can kind of take the entire thing off. You may get these little attachments sometimes. You can use any blunt instrument like a spatula to separate those. And this is a pretty good outcome. You can see that the bed is clean, and you just need to put your graft. So this is just a representative picture showing a nice clear graft with a smooth interface 1 day post-op. In keratoglobus, it kind of just peels off very easily, in fact, because the attachments are very poor. Like a LASIK flap, it comes off. And even in therapeutic dalks, because the cornea is edematous, once you reach the interface, it really peels off quite nicely. This is a patient of acanthamoeba keratitis. It's not like you can't have a perforation. If it's an old hydrops, you can have a perforation like that, but luckily most of these microperforations can be managed without converting to a penetrating keratoplasty, and good outcomes. So this patient did quite well. So this is one of the patients. One eye I have done a big bubble talc, and one eye I have done a talc with the groove and peel technique. And you cannot say which was done by which. Both are equally clear and had an equally good visual outcome. So manual techniques are a good alternate to big bubble, especially in difficult scenarios. The groove and peel technique makes manual talc safer and more predictable. And it's, sometimes if it doesn't go as per plan, you can always use principles of various techniques to arrive at your own manual technique and get good outcomes with talc. Sometimes if you even leave behind some stroma, it doesn't really matter. Over time with remodeling, most of these patients actually do quite well. And even if you do have a perforation and you're leaving a little bit of stroma, it clears up over months or years, and almost gets equally good outcomes like a big bubble talc. Thank you.
I'm always amazed when I see this technique of yours. I have two questions. One is, if you have noticed pre-operatively that there is scar down to the Descemet's membrane, would you still attempt this procedure?
Yes, I will just go to the scar area in the end. So go all around and peel that area very slowly towards the end. And if there's too much of adhesion, then I'll probably use a crescent and just leave a little stroma in that area, and that's okay.
And the second question is, if you have a perforation while you're doing this peel,
Yes.
Do you see that there's a tendency for the perforation to extend?
If you rip it, that will happen. If you go gently, so over time I've learned not to just pull in one stretch. I go slowly now and do it in small steps. So if you have a perforation, you can usually manage it. You put an air and you won't really have a problem. Yeah. Thank you.
Thank you very much, Dr. Rishi, for that amazing technique. Now we request Dr. Anandati Anshu, our chairperson, to give her talk. She will be speaking on the problem.
For the conference again this year, and I would like to thank the committee for inviting me here. There has been a lot of discussion on whether we should just go for a PK or should we try and do lamellar surgery no matter what. I have no conflict of interest to declare. I think I'm one of those who would like to do lamellar surgery no matter what. Because over the years, when I used to do PKs in the very early days, and I see these patients several years later, every time they come into the clinic, I'm worried they have a problem that will be hard to manage. And with lamellar surgery, we've realized that, the clinics are so calm. Patients come and go, they are stable year after year. And definitely, there is no doubt that lamellar corneal surgery has advantages over PK. But there are occasional scenarios like some that were presented earlier today. The question we have to ask is, do we do a PK or do we do a staged lamellar procedure? And how risky is it to do 2 lamellar surgeries? So let's see if I can answer some of those questions today. So this is the first case of a patient who had very bad acanthamoeba keratitis. It took almost 8 to 9 months to heal with a combination of medications. We all know the anti-acanthamoeba drugs cause toxicity and inflammation. There was a lot of stromal scarring and thinning, dilated pupil, which is not uncommon because of the high IOP. So in the first instance, I performed a manual DOLC for this lady. And despite the manual DOLC, she continued to have persistent edema. And again, I suspected it's because of endothelial dysfunction, which is again not uncommon in patients with acanthamoeba. So the question at this stage is whether we should do a PK or something else. So I decided to we waited for a couple of months for the eye to be more calm. We had intensive steroids, and we went ahead and did a phaco DSEC with an iris prosthesis. And this patient is now more than 15 years out and continues to have clear and good vision of 6/9. What about, so this is the picture at 1 month post-op when her cell counts were 2,500. Currently her cell counts are in the range of 700-800, but she's still doing very well with a stable clear graft. This is another patient who had a PBK and had a DSEC done, uneventful. 3 months post-DSEC, she started developing these stromal opacities, which we were not sure what it was. When we scraped it after at least 6 weeks of trial because we were not sure what's happening. We were not suspecting it to be microsporidia. Then once we suspected it, we sent scrapes again for microsporidia and it came back positive. So it's one of a few cases of stromal keratitis due to microsporidia. We hardly see that in Singapore. I'm sure in India you see a lot of stromal keratitis secondary to microsporidia. So once the epithelial lesions cleared, she was left with this dense stromal keratitis that continued to increase in size. And she's had a previous DSEC. So again, instead of doing a PK, we decided to do a DOLC on her. She has poor vision post-operatively because of diabetic maculopathy and macular scar, but the graft has remained pristine and clear more than 10 years post-op. The third case is a patient who had Fuchs endothelial dystrophy with a lot of stromal edema and scarring. So the DSEC was done. And after the DSEC, she came back to a vision of 645 because she had a lot of residual stromal scar and flattening with almost 13 diopters of sphere and 10 diopters of cylinder. So then I went on to do a DM-bearing DOLC more than a decade ago, and she continues to enjoy excellent vision post-operatively. So this is another example where instead of converting to PK, a DOLC over a DSEC can be done very easily. And believe me, this surgery is a lot easier. If you have a DSEC there, all you need to do is inject a bubble into the eye, and that plane of cleavage, the plane is very easily achieved. This is another patient with a bilateral thermal burn with endothelial dysfunction. This patient had both anterior scarring with vascularization as well as endothelial dysfunction. So both eyes were managed differently. So let's go to the left eye first. The discussion was whether the patient should have a PK or patient should have a staged procedure, do a anterior lamella procedure first, followed by an endothelial procedure. And once we had this discussion with the patient approved of the idea and went ahead to do an ALTK stage 1 because it was a very superficial corneal scar, followed by an ALTK stage 2 and a combined phaco DSEC for this patient. So this patient, his left eye has this surgery. And after the surgery, of course, it's a trilaminar cornea. Initially, the cornea was very edematous. Over time, it settled down, and the patient recovered very good 6/9 vision. How about the fellow eye? And at 4 years, the cell counts are at 1,346. So this patient has been doing very well in the left eye. The right eye, however, had a PK. Of course, with PK, we know the quality and the quantity of vision is excellent. 3 years later, patient had a rejection. It was reversed, but her endothelial cell counts have reduced to 1,675. I mean, at the moment, both are doing fine, but we know that it's a matter of time. Over time, the risk of PK failing is a lot higher. So I think after having done several cases, there is enough evidence now to show that rather than doing a PK, combining 2 lamella procedures have a lower risk of rejection as well. So as I mentioned in case 1, the acanthamoeba patient with stromal scarring, a DOLC was a reasonable first option, And if there is endothelial dysfunction, once the eye calms down, a phaco-dissect might be a better option in terms of long-term graft outcomes. Doing a manual dissection under a dissect is very, very easy. It's a lot easier than doing a manual DOLC for, say, keratoconus or other stromal scars. Just avoid suction trephines. It has to be, trephines like the Solan trephine are good enough, and they give you excellent outcomes as well. And this patient particularly did pretty well despite having limbal stem cell deficiency. A lamella procedure resulted in a very good outcome for this patient over the long term. Thank you. Before I end off, I would like to actively invite all of those who are interested to join our one-year international fellowship program in SNEC. It's a fully funded fellowship program. So anyone who is interested, we offer 10 to 12 fellowships. So please come and look for me. Thank you.
Thank you so much, ma'am. Any comment from the panel?
I think it's the excellent technique. We would definitely have it to add to our armamentarium. The only disadvantage for me is that you need to use 2 corneas for 1 eye. So that means that in case you have enough corneas, it might be a viable approach. In case when you have a shortage of the donor material, that might be a little bit more not so straightforward, I should say.
I agree, yes. I mean, with the shortage of cornea, yes, that's a problem. But I think if you look at it from a longer term perspective, the advantage it offers for our patients, I think it's still worth the wait, getting a lamella surgery done. Thank you.
Thank you so much. May I now request Dr. Anand Parthasarathy for his talk on viscodissection for type 2 bubble.
As my slides come up, Arundhati, can I apply? So I was just also curious whether you looked at any interface when you put an OCT over long term, because in SMILE very occasionally, even just with lenticule removal, there is some interface haze which takes about 3-4 months to really settle down.
When we did our initial series of Hulk cases, where we did not want to go all the way down to the Descemet's membrane, we did notice that there is a lot more haze. And when we followed them up over a year, 2 years, and 3 years, the haze actually continues to settle down over time because of stromal remodeling and keratocyte remodeling. So it does reduce, yeah.
And ever tried combining it with like a limbal stem cell transplant? Is you doing such a lot of extensive dissection, limbal stem cell deficiency? No.
No.
My videos have also been translated.
We would have a group photograph at the end of the session, and we would request our audience to ask all the questions at the end of the session. Meanwhile, is there any questions from the audience? Till sir is setting up the system. So he's on. Over to you, sir.
All right. Thank you. And it's a pleasure to be among friends again. I'll just stick directly to the point about why type 2 bubbles are important. Type 2 bubbles occur in about 10% of the total big bubble DALs. And the type 1 bubble, I'm sure there are some among us who get 80-90%, but the range is about 40 to 80%, depending on the surgeon, technique of injection of the air, the amount of dissection that you do. And if you have a type 2 bubble, there are higher chance of conversion to PK. Now there are some predisposing factors for which the type 1 bubble you will not get, you will probably get a type 2 bubble. One is superficial air emphysema, and that's one reason we described way back in 2004 when I was with Anshu and SNEC to actually do a superficial lamellar keratectomy before you actually inject. The advantage is that the chance of getting the type 1 bubble is a lot more, especially in keratoconic patients. If you have a patient with macular stromal dystrophy or any corneal scar, You can get a type 2 bubble because the dissection in the central part that doesn't seem to be very good. The air escapes to the periphery and then the bubble then starts from the periphery. Very occasionally in advanced keratoconus, when you try and inject a bubble, you end up with a type 2 bubble as well. Now this is a partial type 2 bubble, and as you inject, you could make out that it starts from the periphery, and it is predominantly in the deeper, in the deeper layers, and you would very rarely sometimes get in stromal dystrophies a complete bubble. Now what that happens is then it changes your surgical plan. And in this patient you can see very carefully that you got a peripheral bubble in one edge of it. This video I got where they had an initial injection itself, you had a complete type 2 bubble. Now this really does change your surgical plan because you can no longer do what you planned for, which was a type 1 bubble in keratoconus. In this, you would definitely have to do a manual dissection, which would be the safest. In the video that they showed, they actually did an incision, they injected visco, and then went ahead with the dissection with scissors. Now, you need to, I'm sure you know that the thin descemetes is actually very, very prone to perforation, even with the touch of the scissors, which does not happen with the type 1 when you get it. And in this series, as they completed the dissection, they exposed the descemes, they were just washing the visco, and sometimes you can get rupture just with that saline. So you got to be very careful in these kind of very thin descemetes where you can get perforation with just flow of the fluid, and you end up converting this into a PK. Now intraoperatively, of course, you can differentiate a type 1 from a type 2 quite easily. You have the anterior surface of the Duval's layers. When you create the type 1 bubble, you have a rough looking surface, few stromal fibers. And in the type 2, you will have a very, very clear descemetes. The surface is featureless, no visible fibers. This type of bubble is more susceptible to rupture, as we can see, because it's no longer protected by the extra 15-20 microns of the collagen layer of the Duval's. There is one small report by Pratik on where he actually did serial OCT. So he got a partial type 2 bubble, he did the dissection, and then he followed it up serially, and the type 2 bubble actually spontaneously reabsorbed. So in a lot of patients, if you get with a type 2 bubble, it's a good idea to go ahead with your manual dissection, and we can get to the pre-descemetic layer, and I'll show you something that I use quite commonly. You can get very, very good results. The option of releasing the type 2 bubble is something you need to take on table. Some people leave it, some people release it, but that's an option you can look at. Now, there's one article which I found interesting was from this group where they looked at the various methods of management of the type 2 bubble. And in these 31 odd patients, they found that when you have basically a type 2 bubble, if you try and do a DM bearing, the chance of conversion to PK is a lot higher. But if you do a combination of manual and a bit of visco, you can get away with a DALC. Now, what is this visco-assisted dissection? Is you do a superficial keratectomy, which I really do prefer. It helps you go deeper. And if you got in this, you can make out a peripheral type 2 bubble. You go if you have an OCT, which some of us do have, it makes life a lot easier. But if you're looking predominantly at the way the fibers separate, you go deeper and deeper, inject a bit of visco into the deeper layers. What that does is it separates the deeper layers. You can go ahead with either an iris repositor or a lamellar dissector, and you make sure that you are aiming to get to the pre-descemetic layer. Of course, you need to avoid using sharp instruments in this point, and you need only about 5 to 6 millimeters of pre-descemetic removal over the pupil to actually get good results. You inject visco, the visco pushes the pre-descemetic and the descemes Duval's layer down. You can do it multiple times. You can inject multiple times of visco injection in the deeper layers. They usually does separate quite easily. Do a peripheral dissection so the plane across the whole bed is actually quite uniform. Once you do that, you can actually come to the center, go deeper. In this, we did try to remove the central part as much as possible. If you do not do a peripheral dissection, they tend to have very irregular healing, and some of them do end up with a fair amount of irregular astigmatism. You find one area where you have a bit of a type 1 bubble, that is a deeper bubble. You inject the visco through that, and with the visco layer, you use basically a broad iris repositor and use a blunt scissors. You can expose the predesmatic layer without actually touching. This works quite well. You can get a very clear bed at the end of the procedure even if you do not bare the desmids. The manual dissection, something of what Rishi describes quite well, is starting from the periphery and then coming into the center, is something that can be done quite well. You just use a blunt dissector, go across, have multiple dissection of the stroma done. What that does is that you have a uniform plane. In these patients, even if you get about 70-80 microns leftover stroma, most of them do well with 612 kind of vision with a pair of glasses. Always do the peripheral dissection before you come to the center if you're doing a manual dissection. The option to use viscoelastic in this is probably less because you do not plan to go down deep. The deeper you go, a better idea would be to use viscoelastic. If you're going more superficial, a dry dissection with a bit of saline usually works quite well. So in summary, deep stromal dissection or expanding the type 1 bubble with cohesive viscoelastic would be the good option. A manual dissection up to the predesmatics give good surgical outcomes. DM bearing techniques should be avoided in the type 2 bubbles if you're not very confident of completing the dissection. And of course, avoid high volume irrigation for type 2 bubbles directly on the stroma. Thank you so much for your attention.
Thank you very much, Dr. Anand.
Should we comment or conclude the session? So the only comment I have is that I like to use viscoelastic to dissect the descemet membrane. If it goes into the predescemetic space, it's fine, but when it goes into the stroma, so it actually infiltrates the stroma, it makes your life a little bit harder rather than easier, because you get the bulk of the stroma. So I believe intraoperative OCT might be very useful in these cases when you have to be sure where you're going. Otherwise, you infiltrate the stroma and then it becomes thicker.
The air emphysema, Dr. Malugan, what gives you is you've got the video where I showed where you got to use a side port or a 15-degree to actually incise that layer, which is before the predesmetic, inject the visco through that, and then it kind of opens up the deeper layers.
Exactly. Yeah.
Thank you, sir. Now we have a talk by Professor Namrata Sharma ma'am on Envision in advanced dry eye. While madam sets up her presentation, we call all the speakers and panel members to come for a quick photograph.
So thank you. So this is a sponsor's talk. So I will be talking about Envision, which is the new modality which has come up for dry eye treatment. Direct lag jayega. So dry eye is increasingly being diagnosed worldwide as well as in our country. Almost 50% of the cases do have dry eye. And meibomian gland dysfunction, there is a prevalence of 35.8% globally, but I think in India it is close to 48 or 49%. There are ways of identifying the dry eye patient, which is done with the ocular surface disease index or various types of questionnaires, like dry eye questionnaire, speed questionnaire, etc. And basically this device that I'm going to be talking about is for the meibomian gland dysfunction. So this is just to show how the healthy meibomian glands would look like, and how when there is a dysfunction of the meibomian glands, then they would look like both on the LipiView or ocular surface analysis, and even this can be picked up by autorefractometer. So once this is there and you have done an evaluation of the dry eye by doing the various tests, which include the upper lid and the lower lid imaging, the tear breakup time, MMP9, which is maybe done in some of the centers, tear osmolarity, as well as the clinical evaluation. There are various methods of treating the dry eye and the meibomian gland dysfunction, and often medical intervention and treatment is required. The conventional approaches do include the medications, lid massage, warm compresses, manual expression of the blocked ducts, artificial tears, and omega fatty acids, although it has been shown that they really do not have much role to play. But there are new technologies which provide new non-invasive options to safely and effectively treat the meibomian gland disease and dry eye, and patients continue to seek customized non-surgical office-based therapies to provide symptomatic relief. So this new technology, that is the Envision, it is safe, effective, and is comfortable, is done as an office-based procedure for symptomatic relief of meibomian gland disease and dry eye. And it is a very intelligent programmable workstation which provides the customizable treatments to address the common eye conditions. And there are multiple complementary modalities, so it is like a multi-station which works synergistically. It is also easy to navigate on the LCD touchscreen. So essentially it is got three kinds of handpieces, and it is a multiple technology handpiece device. Forma 1, which is non-invasive, and which is the first bipolar radio frequency probe which has been devised. Then Lumeka 1, which is about 8 millimeters in size. It has a small tip and works on the intense pulse light technology. And I think the inventor of intense pulse light technology is also associated with this Envision technology, and this is mainly for dry eye as well as inflammation. And the Morpheus 8, which has a probe of 1 to 4 millimeters, the principle of which is microneedling, and subdermal adipose remodeling can be done with it. So I think this is more for the oculoplasty people, for puffy eyes, etc. But I think for the cornea specialists, it is the first two, that is the Forma 1 and the Lumeka 1. Small size applicators are there and gives you a precise depth control also, so these procedures can be undertaken. This is how it looks like, the Lumeka 1 spot size intense pulse light. And this ensures precise targeted spot size procedures to treat inflammatory conditions in smaller zones, that is up to 8 millimeters. And it also has light guide cooling along with it, so it does not completely cause burning of the skin, or burning of the skin which is close to the meibomian glands. So the second one is the Lumeka, which uses light energy, which reduces inflammation, and the light wavelength is selectively absorbed by the telangiectatic blood vessels, which coagulates them. So essentially on the principle of IPL, and it also reduces the load of the demodex mites that stimulate the infection, and it stimulates collagen synthesis as well. And indirectly it interrupts the dry eye inflammatory cycle, the vicious cycle that is there, and that is how it affects. The Forma 1 treatment is used to address dry eyes, and it intended use in the periorbital area and the eyelids, and relieves the inflammation of the meibomian glands and the eye irritation. And these are the specifications. There are 2 electrodes basically which are present, and the distance between these 2 electrodes is 4 millimeters. And basically it is the dual electrode which acts on thermal technology, and radio frequency is the principle by which it acts. Again, it is quite efficacious, and it is kind of non-invasive and will relieve the symptoms of MGD as well as dry eye. Now it is fast, it is effective with a bipolar radio frequency, and first radio frequency device which is available. And I think this we can leave just to show a small animation on how it works. So this I have already told you, it basically has 3 probes which are there, which are available with this instrument. So it helps in the dry eye with or without the inflammation, and also helps in the in cases of puffy eyes as well, and so can possibly be also used by the oculoplasty surgeons. So the treatment protocol is that for MGD you use Forma 1, and for MGD with inflammation you use Forma 1 with Lumeka, And the third one is actually used by the dermatologist and probably will not fall into our armamentarium. This was it. Thank you so much for your kind attention. Naresh. So Naresh is here. Naresh, can you tell the cost? Are you allowed to disclose the cost? We've not bought it in RP Center yet, but we are going to buy it very soon. So there are more than 10 here, so you have to give discount to everybody. So there are no disposables, no disposable cost at all, and no hidden cost. But then you've been very honest in revealing a price in amongst so much of audience. Nobody actually does that. They, you know. Okay. Okay.
When it comes to the effectiveness of these handles, I would always say, salespeople would always say good about their product. Let the machine speak, that's what we always say. We would always encourage a demonstration of this machine to, if you feel it like that, okay, you have a space in your practice. Let the machine speak and you see it yourself, the kind of...
Okay. Thank you. Thank you so much. Thank you.
I believe that concludes the
We
session.
now request for the group photograph.
Finished. Yeah. Thank you.
Thank you so much for being such a patient audience. Namrata ma'am, you too, please. Group photograph.